Great, thank you. Thanks for having us. We're excited to present some of our work. I'm Kelly Getz. I'm a PhD epidemiologist at the University of Pennsylvania and the Children's Hospital of Philadelphia. My work is primarily focused in the treatment and supportive care of children with pediatric leukemias, with a particular focus in the cardio-oncology of acute myeloid leukemia. So I'm going to start off the presentation with some of my prior work focused mostly on the occurrence and impacts of cardiotoxicity on pediatric AML patients, and then some overview of our work with exploring desoresoxane for cardioprotection. And then I'll hand it over to Kasey for her part of the presentation. So just by way of background, and I know I'm not saying anything novel to this group, but anthracycline regimens, anthracycline-based regimens have contributed to the significant improvements in overall survival among pediatric AML patients. But these intensive chemotherapy regimens are also known for their high risk for cardiotoxicity. While much of the research in cardiotoxicity in pediatric cancers has focused in the long-term survivorship, our work is more focused on the acute early impacts of the anthracycline-based regimens on cardiotoxicity. We know that survivors experience a risk for cardiomyopathy and cardiovascular disease, but cardiac dysfunction detected during and shortly after treatment may contribute to acute early treatment-related deaths, reductions in anthracycline exposure, which may limit the curative impact of the chemotherapy, and then lead to reductions in event-free and overall survival. In fact, our prior work evaluating the impacts of early cardiotoxicity on treatment outcomes for patients treated on the previous COG trial, AAML0531, demonstrated that both 5-year event-free and overall survival were significantly reduced in patients with documented cardiac toxicity during or shortly after treatment. So the focus of the next few slides will be on the incidence of cardiotoxicity in this patient population, identifying subpopulations that may be at particularly high risk, evaluating again the impact of cardiotoxicity on event-free and overall survival on the subsequent trial, AAML1031, a review of the cardioprotective impacts of desoresoxane, and then a brief overview of our analysis of resolution of our early cardiotoxicity. Just by way of overview, I wanted to orient you to the chemotherapeutic regimens that have been utilized on the 2 trials that I'll be focusing on, AAML1031 and AAML0531. Based in part on MRC AML12 results, the most recent COG trial 1031 eliminated the 5th course of chemotherapy for the treatment of non-high-risk AML patients. So specifically, such patients were treated with a 4-course chemotherapy backbone, including 2 induction courses of cytarabine, daunorubicin, and etoposide, followed by 2 post-remission consolidation courses of cytarabine and etoposide, followed by cytarabine and mitoxantrone. The prior trial utilized a 5-course chemotherapy backbone for low-risk patients. The removal of the 5th course of chemotherapy on 1031 resulted in a reduction in cytarabine exposure, but importantly, the anthracycline exposures on the 2 trials were identical. Among high-risk patients, on both trials, they generally utilized 3 courses of chemotherapy plus a stem cell transplant. At approximately 300 milligrams per meter squared, their cumulative anthracycline exposure was therefore about a third lower than that received by low-risk patients. Cardiotoxicity was a targeted toxicity on AML 1031 in contrast to the previous trial 0531. Therefore, a more intensive echo-based monitoring schedule was employed, and echoes were required prior to every course of chemotherapy, at the end of protocol therapy, and at 6-month to yearly intervals during off-protocol follow-up. The lowest shortening fraction and ejection fraction in each reporting period were required to be submitted to COG, and the per protocol cardiotoxicity was defined as a fractional shortening less than 28% or an ejection fraction less than 55%, which represented the protocol mandated thresholds at which anthracyclines were to be withheld. Higher grade toxicity, defined by shortening fractions less than 24% and ejection fractions less than 50%, were consistent with grade 2 or higher left ventricular systolic dysfunction per CTC AE version 3 definitions, and these were also evaluated to get a sense for the higher grade toxicity. Resolution of cardiac dysfunction was defined as fractional shortening returning to baseline or greater than 30%, and ejection fraction returning to baseline or greater than 60%. Echo compliance on 1031 was overall high at about 74% overall, but higher and less variable during on-protocol therapy, where it ranged from 88 to 97% at each course, compared with 58% during off-protocol follow-up. Echo compliance during the on-treatment period on 1031 was higher than previously described on the previous trial AAML 0531, likely due to the more frequent echo monitoring and the required reporting of the echo measurements, ejection fraction and shortening fraction. However, the requirement to submit echo measurements did not seem to improve the off-protocol compliance, suggesting a potential differential mechanism for decisions regarding monitoring and potentially an area for additional research. As a result of the high compliance with monitoring, the documented rates of grade 2 or higher LVSD were greater on 1031 at about 21% compared to the previous trial 0531 at 12%. A similar trend was observed at the, among the course-specific prevalences. Over a median follow-up of about 3.5 years, 428 patients experienced protocol-defined cardiotoxicity for a cumulative incidence of about 39%. Of those patients, approximately half suffered grade 2 or higher LVSD for a cumulative incidence of about 21%. Cumulative incidence was higher among non-infants and female patients. Cardiotoxicity was also higher among patients who were randomized to receive bortezomib and those with low-risk disease who received more cumulative anthracycline during frontline therapy than those with high-risk disease. Whereas patients who received desrizoxane for cardioprotection were less likely to experience cardiotoxicity. Importantly, the incidence of per protocol cardiotoxicity and grade 2 LVSD did not differ by race, ethnicity, or white cell count at diagnosis. With respect to the impact of cardiac toxicity on treatment outcomes, both event-free and overall survival appear to be worse in patients with grade 2 or higher LVSD. However, the impact was larger and statistically significant for overall survival compared to event-free survival, suggesting a potential difference in salvage upon relapse for those who experience cardiotoxicity early in therapy. Now, with respect to desrizoxane, we'll dig a little deeper into those analyses. Prevention or mitigation of cardiac injury during treatment is necessary, obviously, to avoid short and long-term morbidity and mortality. We know that desrizoxane has been shown to reduce anthracycline-related cardiotoxicity in adults with solid tumors and in children with a variety of malignancies. 2 studies that evaluated desrizoxane exposure in pediatric AML, however, have been limited by small numbers or a lack of internal controls. Therefore, we decided to explore the exposure to desoresoxane and its cardioprotective impacts on 1031. Desoresoxane exposure was evaluated, and the decision to administer desoresoxane was at the discretion of treating physicians on 1031. Approximately 16% of the study population were exposed to desoresoxane during frontline therapy. Of these, a subset of patients were exposed during some, but not all, anthracycline-containing courses. The majority of these patients did receive desoresoxane prior to their initial anthracycline course, but rather had it introduced at subsequent courses. This group would include some patients for whom Getz was initiated in response to, say, subclinical declines in cardiac function. As such, those patients were included and excluded, and our analyses were focused on a comparison between those patients who consistently received desoresoxane at every anthracycline-containing course and those that never received desoresoxane during frontline therapy. Just by way of overview, despite the non-randomized nature of our study, distributions of sex, age, race, and ethnicity were similar for the desoresoxane exposed and unexposed patients. Likewise, distributions of weight status, initial white cell count, risk classification, and randomized treatment were also comparable between the two groups. The overall incidence of cardiotoxicity was about 19% across the entire study population. And among patients who consistently received desoresoxane at each anthracycline course, the incidence was 8% compared to 21% among those never exposed. Thus, desoresoxane was associated with about a 70% reduction in risk for cardiotoxicity. At each treatment course, the overall prevalence ranged from about 2% to 11%. And the reduced risk for cardiotoxicity among patients exposed to desoresoxane appeared to be achieved through a preservation of cardiac function. Desoresoxane exposed patients had similar declines in shortening fraction than exposed patients across courses. And despite some evidence of recovery in the early off-protocol follow-up, shortening fraction remained lower among the unexposed compared to those who were exposed to desoresoxane. Additionally, based on modest sample sizes, there was a suggestion of further worsening later in follow-up among those unexposed that was not apparent in the patients who were exposed to desoresoxane. This same temporal trend was observed for ejection fraction patterns. Due to concerns over the potential for desoresoxane to potentially interfere with the cytotoxic effects of anthracycline-based chemotherapy, we further explored the impacts of desoresoxane on event-free and overall survival. And desoresoxane did not worsen overall or event-free survival. However, desoresoxane-exposed patients did experience lower risk for treatment-related mortality than unexposed patients, a difference that approached statistical significance. There was a 53% lower risk among those exposed at 5.7%, a rate of 5.7% versus a rate of 12.7%, suggesting that desoresoxane may directly prevent acute severe cardiac events that contribute to early deaths. Lastly, we explored the potential discrepancies in non-cardiac toxicity profiles by desoresoxane exposure status. And we saw that the median durations and corresponding of courses and the corresponding durations of neutropenia were comparable between the two groups. Likewise, we saw that the rates of microbiologically determined bloodstream infections and mucositis, as well as ICU level care requirements at each treatment course, were not meaningfully different between those who were treated and not treated with desoresoxane. Lastly, I wanted to present some of our preliminary results evaluating the potential resolution of early cardiotoxicity. We found on 1031 that among the 232 patients who experienced grade 2 or higher left ventricular systolic dysfunction, that 114 or 49% experienced recovery of cardiac function within a median of 14 months from the initial detection. High-risk disease classification, again, those are the individuals that had lower anthracycline exposure, and desrizoxane administration appeared to be associated with a greater likelihood of LVSD recovery. The likelihood of resolution did not differ by age, race, ethnicity, initial white count, or treatment arm. In conclusion, we know that the required submission of echoes leads to better compliance and more documented cardiotoxicity. Approximately 20% of pediatric AML patients on 1031 developed grade 2 or higher LVSD, only half of whom had documented resolution of cardiac function to grade 0 or baseline. Lower anthracycline exposures and desrizoxane were both associated with the occurrence of a lower occurrence of cardiotoxicity and superior recovery. We know that that desrizoxane did not alter the non-cardiac toxicities with respect to AML therapy, and that lower exposures and lower anthracycline exposures and desrizoxane were associated with both reduced LVSD risk and recovery, and that desrizoxane did not impact the cytotoxic effects of the chemotherapy, though did appear to have a suggestive, though statistically not statistically significant impact on early treatment-related mortality. I just want to thank my collaborators and acknowledge my funding sources. And with that, I'll hand it over to Kasey. Let me pull up your slide deck.
So, Dr. Getz, this is Dan Linehan at WashU in St. Louis, and thank you so much for your presentation and also really fantastic data. It's quite amazing, actually. But in what you're reporting on, that sort of two basic things. Number one, that when you hold people who are doing echoes to a higher standard, meaning they have to communicate that echo to some other entity, then compliance is much better, but also quality is better. So that's an unbelievably important point. And then your whole discussion about desrizoxane is really fantastic. I think we just published a paper in cancer clinical research that was in patients with sarcoma, in which we used desrizoxane up front. And so at the very beginning, when they were beginning anthracycline use. And I mean, I'm sure you're probably aware, the adult recommendations for the use of desrizoxane are very limited.
Yeah.
And they're limited based on a study in 1990. So I think that something happened back in the day and scared everybody off, and ever since then we've not been using it, and that is such a shame. And then showing it in the pediatric population, how it's even more important. I mean, that makes perfect sense. But really fantastic presentation, and we're totally behind you guys. We absolutely, whatever we can do to try to change the nature of cardio-oncology's view of the use of desrizoxane is this is an extremely important point. So congratulations, for sure.
I think, I mean, your point is so well taken, that the impact that it really shows the impact that one study with, I would say, suggestive results can have on care. And, historically in just the pediatric leukemia patients, desrizoxane has been used in less than 10% of patients. And I do think it's that reluctance based on, some early studies that suggested, potential secondary malignancy risk. And, since then, the data have demonstrated that this, that risk may not be as strong. And I think you have to think about this, that risk in the setting of each individual disease. When the risk for relapse far exceeds your risk for secondary malignancy in AML and the risk for cardiotoxicity, I think you need to swing the balance the other direction and really, consider that the utilization of something that is proven to be so successful in cardioprotection. And the data on the early treatment-related mortality tell you that it's having a direct impact on preventing those potentially most severe cases. I'll leave the sort of the bit around maybe how can we get, ignite the greater utilization to Kasey's presentation, because, she'll demonstrate sort of what is, now being protocolized from a COG perspective. But I really appreciate your comments and feedback. And, I'm biased because I feel so, excited by this work, but it's great to hear other people who are also just as excited about this work.
Yeah, no, fantastic. And I definitely look forward to Kasey's presentation. The other point that I would make about the paper in adult patients with sarcoma is that overall survival was actually improved in the population in which we used desrizoxane. And you could argue two basic points there. One is that you protect them better from a cardiac point of view, so you have less cardiac manifestations. But then also, you're able to treat them for a longer period of time with anthracycline. And so that has an important impact on the cancer. And that's exactly the opposite of, as you know, and as you've stated, the sort of long-held belief that it somehow impacts cancer therapy. It actually doesn't. It enhances it. So.
Yeah.
Hi, can I ask a question here too? This is Ron Kern. I'm also in on the project, and as Dan mentioned, we did see a improvement in the progression-free survival compared to historical controls. And I noticed that you didn't seem to have any impact on survival. Of course, you didn't have a large, you actually had a lot of people in there. But what we basically saw was that we were able to give more cancer therapy because we weren't limited by cardiac toxicity, and almost had no toxicity at all in about 75 patients with an improved survival in many. I know many of the people obviously didn't survive actually, but it did seem to improve considerably. Do you have any data on that? And the other question I have is do you have a reference?
Oh, yes. So both of these papers, I apologize for that. So both of these papers are available in JCO. I can circulate or I could maybe even pull them up, but and have them for when Kasey finishes her presentation, the actual full citation. But they're both published in JCO, one this year, one the preceding year. Regarding your question about, us not identifying a event-free or overall survival impact, I do think in part that is due to the very small number of patients who are treated on with desrizoxane on the trial, because it was non-randomized. It was really up to sites. So I think we achieved balance, non-confounding because of the nature of it being, practice-based, institutional practice-based, but that there are so few patients that the true and the occurrence of cardiotoxicity, while sort of more common than we originally thought, it still occurs in a minority of patients. So in order to really appreciate the difference, I think we need to see more desrizoxane exposure, and then you would be able to, sort of see that causal contrast to express itself in the data.
And a quick follow-up. Did you have any clinical heart failure in these kids? We found that there was very little clinical heart failure, even though there might be some changes in the ejection fraction, which actually never got very bad. Was there some clinical statement there?
Yeah, so that's a, an awesome point. So in the paper itself, we explored the sort of the occurrence of cardiotoxicity even deeper than I had presented here, and demonstrated that the likelihood to approach, the grades of clinical decline that would be consistent with heart failure were almost null. I think there was 1 or 2 patients on the desroxane exposed individuals that actually experienced declines consistent with heart failure, but there were many more in the non-exposed group. So the progressive benefit of, or I should say, the benefit of desroxane, the magnitude of the contrast was greater for more severe toxicity, which demonstrates that you are preventing declines and preventing the worsening of the cardiac toxicity, such that you detect the cardiac toxicity. When you do detect it, it's at lower grade and less likely to progress. Whereas in the setting of not receiving the desroxane for cardioprotection, you detect it and you are more likely to see the progressive worsening through increasing grade of toxicity.
Thank you very much.
Yeah, sure.
Hi.
Hi.
Dr. Getz. Hi, it's Veronica from Brazil. Thank you very much for your presentation. Congratulations for your work. I'm very happy to be part of this big team here now. And now I'd like to talk just a little about our experience here. There was an old idea of safe dose some time ago that we usually had 300 milligrams per meter square as a safe dose of anthracycline, and then we were allowed to start dexrazoxane in our children. So we could show in our old protocol of osteosarcoma protocol that more than half of our patients really developed acute cardiotoxicity detected by a conventional echocardiography. Imagine nowadays that we are using global longitudinal strain that's much more sensitive, and now we changed the protocol and we are using just since the first dose, of course, of anthracycline, and we are not seeing anymore any significant drop in global longitudinal strain or ejection fraction. It's amazing the results. No heart failure, as our colleague was questioning too. And so I'm very, very, very happy to use. It's very safe, no secondary malignancy, no nothing. And so we need to work to improve and to develop and spread the idea of the safety in the importance of the use of this cardioprotection. Thank you very much for everything.
Oh, thank you for sharing that experience. It's so reassuring to hear that those, positive, those small changes in practice can have such, significant and meaningful implications on the results in those kids.
Oh, I don't want to prolong this. This is Joe Carver from Philadelphia. That was excellent. There's one piece that's still missing that I often get pushed back, and people say it costs too much to use dexrazoxane. So do you guys have the ability to do an economic analysis of the cost of the people that got it versus the people who didn't get it with downstream costs, and to show that even economically that there's a big return on investment?
Yeah, I think that's an excellent idea for a study. So the one data, so if I'm just thinking out loud, the one data resource that I can think of that we have done, cost analyses in is the Pediatric Health Information System, which is an administrative data resource. Now, the limitations of that are that it really is on inpatient costs. So you can imagine that we could benchmark the two treatment arms with respect to their on-treatment period, for which AML is almost entirely inpatient. And then you can imagine that if there are severe complications or you know, sort of worsening of you know, cardiac function such that it requires repeated readmissions, we would be able to detect that in that data source. I could say that's it. That is, you know, sort of low hanging fruit. That's an analysis that we could easily do. We already have a COG-FIS merged cohort in which we could explore that. The piece that would be missing there is all of the incidental costs on follow-up that would not occur in the inpatient setting. I think you're exactly right that all of that sort of the preponderance of evidence is what will be the flip in that the reluctance to utilize the desoresoxane. I'd have to think a little bit more, particularly in the pediatric setting, how to get enough numbers outside of the FIS setting in order to evaluate costs on a more than inpatient resource setting. But agree, great suggestion. Okay, so Kasey, I'm going to pull up your slides now.
Okay, sounds great. Thank you, Kelly.
Sure.
And I can say from someone involved in the Children's Oncology Group AML committee that we are sold, and Kelly's data that she just presented has really shaped the design of the currently ongoing phase 3 trial. And so I think the COG trials really do set the standard of care in pediatric cancer. And so we are giving desoresoxane in the context of this trial. And I think really just want to give compliments to Kelly and Richard Affleck for their work, because it really has changed the standard of care in pediatric AML. So I'm going to switch gears a little bit in light of the background data that Kelly presented on the sort of prevalence and the impact of cardiotoxicity early, during, and soon after AML therapy, and its impact on not only cardiac outcomes, but leukemia outcomes. I want to talk about another consideration for primary cardioprotection with the use of liposomal anthracyclines. Next slide.
Oh, it's not advancing. Hold on.
No problem.
There you go, sorry.
No problem, thank you. I've just listed my disclosures. Jazz Pharmaceuticals is the sponsor of CPX-351, a liposomal formulation of anthracycline, and they are funding the ongoing COG trial as a sponsor of that trial with the NCI. And then I have research funding with Abbott Diagnostics. Next slide. So probably this audience is familiar with liposomal anthracycline formulations. They've been around for quite a while. There are a number of different formulations of doxorubicin, pegylated liposomal doxorubicin, and liposomal daunorubicin. And there's newer combination agents that have recently come to the horizon, which I'll talk about in a moment. But the appeal of a liposomal agent is twofold. I think one, there are favorable pharmacokinetic characteristics that can prevent higher spikes of anthracycline and potentially reduce toxicity in that manner, but also prolong the drug in the circulation so that it can optimize the sort of anti-cancer effect. But then also from a cardioprotective standpoint, these liposomal encapsulated drugs have less ability to get through the tight capillary junctions of the heart, And preclinical studies showed that there are lower concentrations of anthracycline in cardiac tissue when liposomal agents are given. The various liposomal daunorubicin and doxorubicins are FDA approved in various settings such as ovarian cancer, Kaposi sarcoma, and multiple myeloma. There is also supportive data in metastatic breast cancer and in lymphoma. And the recommended use is that it be considered in other settings in patients who have high risk for cardiotoxicity, such as those with advanced age, cardiac comorbidities, or high prior anthracycline exposure. There are a number of randomized studies that have been done over the years that demonstrate that the risk for both clinical and subclinical cardiotoxicity in the adult setting is reduced with the use of liposomal agents. And on the right panel, I have one of the early meta-analyses of 9 studies of liposomal versus conventional anthracycline in adults, featuring about 2,200 patients that showed a significant protective effect of liposomal agents with an overall or with an odds ratio of 0.33. We've also had some experience in the pediatric world with smaller studies showing protection. The leukemia or AML setting specifically has looked at donazome or liposomal daunorubicin in the context of AML therapy, and that's been executed by the BFM, which is the European kind of equivalent of COG. They've looked at using donazome for intensification in the relapse setting with a randomized study adding donazome to FLAG, which is fludarabine and cytarabine, and showed improved efficacy with comparable toxicity, including cardiotoxicity, with the addition of donazome. I will add that that study did not include really detailed cardiac phenotyping, and really it was just based off of cardiac adverse event reporting. They've also shown that donazome can be given during induction in the upfront setting at a potentially higher than equivalent dose to idarubicin, and that without increase in toxicity. Next slide. Okay, it looks like maybe there's some, there you go, perfect. Okay, so that brings me to talking about CPX-351, which is a liposomal formulation of cytarabine and daunorubicin. This has been recently FDA approved in both adults and children with therapy-related AML or AML with MDS. This specific agent has a liposomal encapsulation of cytarabine and daunorubicin at this fixed molar ratio that is superior from a leukemia efficacy standpoint and optimizes sort of leukemia killing, and has been shown clinically to have superior response rates compared to the standard daunorubicin and cytarabine in various settings, but one of the sort of primary or landmark studies was in elderly patients with AML. On this study, they did see similar rates of cardiotoxicity between the liposomal agent compared to conventional anthracyclines. However, the CPX arm, the progression-free survival was longer, such that these patients were able to get more consolidative anthracycline delivery, and so the CPX arm ended up having higher anthracycline exposure, yet still had similar rates of cardiotoxicity. The Children's Oncology Group has recently studied CPX-351 in the context of relapsed pediatric AML, which I'll talk about briefly, and this is under active investigation in de novo pediatric AML as well, which I'll also speak about. Next slide. So first we'll talk about AML 1421, which is a study of CPX in the context of relapsed pediatric AML. On this study, CPX-351 was given on days 1, 3, and 5 for a total delivery daunorubicin dose of about 180 milligrams per meter squared. For cycle 2, patients received a non-anthracycline containing intensive chemotherapy block and then came off study. Those who achieved remission proceeded to allogeneic stem cell transplant. You can see with the numbers there that this was a very small study with only 38 patients enrolled. And if you could press enter. Sorry, Kelly, there's some animation here. And the right panel shows the efficacy data, which was quite remarkable, with an 80% complete response rate. And that's about 10 to 20% higher than any previous response rate in the setting of relapsed pediatric AML. You can see in these Kaplan-Meier curves that the overall survival was about 50% in all patients, but that in those who had a complete response, the overall survival was about 70%, which is quite remarkable for relapsed pediatric AML, which historically has a very poor prognosis. Next slide. So within the context of this trial, we wanted to look at detailed cardiac data to try to understand the impacts of CPX-351 in the setting of a very heavily anthracycline pretreated population. For participation in the trial, patients had to have a LV ejection fraction of greater than 50%, but this was based on the site measurement, not on the central quantitation. The study included optional embedded cardiac correlatives, and that included submission of DICOM echo images at baseline and at the end of the first cycle, as well as serial plasma collection for analysis of troponin and NT-proBNP also during the first cycle. The cardiac analysis was restricted to patients who consented to the cardiac studies, but then also had measurable ejection fraction both at baseline and at end of cycle 1. You can see the study characteristics divided into patients who were included in the cardiac analyses and those who were excluded. The bottom row features the reason for exclusion. There were 6 patients who either refused consent or did not submit a DICOM image, and then another 7 patients who had a missing ejection fraction either at baseline or the end of the first cycle. You can see that the patients who were included in the analysis were a bit older with a median age of 12.5, but the range was between about 1.5 to 21 years of age. Or slightly more of a male predominance in the patients included in the cardiac analysis as compared to those who were excluded. I will point out that about 70% of patients had less than a year for their duration of their first remission, which really shows you, number one, this is a very high-risk population when it comes to their leukemia outcomes. But number two, this population is very close to their upfront anthracycline exposures and all of the toxicities associated with that therapy. Skipping down, looking at just cumulative anthracycline dose, those included in the study received about 350 per meter squared, and this is not accounting for the higher cardiotoxic equivalent dose of mitoxantrone that's been more recently published. And then I'll also point out here that for those included in the cardiac analysis, the presence of grade 3 or greater infection was in 52% of patients. And we'll just call out here that this is very intensive chemotherapy, and it is very common for these patients to require ICU level of care for septic shock or other infectious complications during their induction. Next slide. We did, in fact, see significant declines in left ventricular systolic function following CPX-351. Based on central quantitation, interestingly, this first bullet and the sort of dot plot of the centrally quantitated ejection fraction shows that in 8 of the 25 patients who were included in the analysis, their ejection fraction was less than 50% at baseline. And remember that the site-reported ejection fraction had to have been above 50% for the patient to be eligible for the study. So there was definitely some lack of concordance there. Looking at the parameters of ejection fraction, global longitudinal strain and circumferential strain, there was a significant decline in both EF and circumferential strain between the baseline and the end of that first cycle, and a trend towards a decline in global longitudinal strain. Looking at the sort of dichotomous outcome of cancer therapy-related cardiac dysfunction, defined as a greater than 10% decline to less than 50%, this occurred in about a quarter of patients following their CPX-351. Based on site-reported ejection fraction, like I mentioned, these were a little bit discongruous, but we similarly did see a decline in ejection fraction based on the site-reported measurements, and saw the decline of greater than 10% to less than 50% in only one patient, but did see other patients who had ejection fractions reported as less than 50%, just without that degree of decline. Next slide. In terms of the cardiac biomarkers, in that first cycle following CPX-351, we looked at high sensitivity troponin, which was detectable in about 2/3 of patients even prior to starting their salvage therapy, and abnormal above 19 picograms per milliliter in 2 patients. Looking at the sort of trends in troponin following their days 1, 3, and 5 of CPX-351, there was some variability throughout the cycle, but there was a statistically significant but sort of modest increase at the end of the cycle, about a month after anthracyclines. NT-proBNP was similarly high in the majority of patients, even at baseline, and we did not see any significant change following CPX-351. Next slide.
So Kasey, on that data right there, if people had the high NT-proBNP, were they at higher risk for developing, LV dysfunction?
That is a great question. So I'm going to talk about that here. Unfortunately, it's a pretty small sample size that we're dealing with. So a lot of these were kind of exploratory analyses, but unfortunately, we did not see any associations with baseline parameters and echo or in biomarkers with their subsequent echo outcomes.
And what's the total? What's the total number of patients? Is it like 25 or 30, or how many is it?
25 patients, yeah.
And then is there? Are you allowed, or can you use desrazoxane with liposomal doxorubicin?
Yeah, that is a great question. Unfortunately, we talked a lot about this in the design of this next trial, and there really is not any data to support the safety of giving desrazoxane repeatedly over the kind of prolonged half-life that you would need to support with the liposomal agents that have, the longer sort of distribution time. So it's not feasible to give desrazoxane along with the liposomal agent. So I'll talk about this in a moment, but the current study is going to be, or is a randomization of a liposomal agent with the conventional anthracyclines with desrazoxane. And I think there's a pretty decent chance that the desrazoxane is going to win out, at least from a cardiac standpoint, compared to the liposomal.
Kasey, this is Vlad Zaha. As you're taking questions along the way, I had one quick question on this biomarker section. So if you, because you mentioned those thresholds for the detection for the high sensitivity troponins, but in this research setting, did you have access to sort of an open range on the lower end of the biomarker detection? So troponin less than that level. And if you did, then did that change the profile? So were you seeing a lower range maybe, but significant in those changes?
Kelly, do you mind going back to the last slide? So we could detect down to that 6 picogram per milliliter, and you can see in the dot plot sort of the distribution of where the patients kind of ended up. I mean, there were certainly a number of patients who had undetectable biomarkers, but quite a few that had low-level detection. So I think, certainly these patients have had, whether it's from their prior anthracycline or the current anthracycline or the infectious and other complications associated with their chemotherapy. I don't think we really know, but certainly there are a significant number of low-level elevations. And I think in the context of 25 patients, it's really hard to try to, make any associations with their echo parameters, unfortunately.
Excellent, thank you. I think that's very helpful. So considering the difference between this chemical toxicity and the usual ischemic related thresholds for these biomarkers. Thank you.
Yeah, absolutely. Okay, next slide. We did just do an exploratory look. If you could go back, Kelly, to the last slide. Just looking at some of the clinical variables and how those that impact the post-CPX, either EF decline or increase in biomarker over time. And we did see that a lower baseline ejection fraction was associated with a greater decline, as was female gender, and then a trend towards an occurrence of a high-grade infection. For troponin, again, the higher baseline troponin was associated with a greater increase over time, as was a lower weight and a shorter duration of your first remission, so a shorter time since your last anthracycline, and again, that high-grade infection. And then for NT-proBNP, again, the higher baseline level, a prior history of hematopoietic stem cell transplant, and then a trend towards a higher anthracycline dose seemed to be associated with an increase in NT-proBNP over time. Next slide. So I think, this is a very small single-arm study in heavily anthracycline pretreated patients, but did demonstrate that there are a significant number of baseline abnormalities in cardiovascular function and in cardiac biomarkers at initiation of salvage therapy. We did see significant declines in ejection fraction and modest increase in troponins, and there were some clinical variables that seemed to have associations with some of these post-CPX abnormalities that may, with further study, inform cardiotoxicity risk with salvage therapy. And potentially, these baseline EF measurements or troponin measurements at relapse may predict a greater post-CPX sort of cardiotoxicity risk manifested as EF decline or cardiac biomarker increase. I will say that, as I mentioned, the site-reported EF declines were similar. I think the one other sort of big limitation of this study is we really only have the biomarker data and the centrally quantitated data at that first cycle. So we don't have the benefit to understand the trajectory of cardiac function over time based on central review, but we were able to get just echo site-reported EF over time. And while the sort of compliance with reporting those echoes really falls off in the follow-up setting, I think we did see that a lot of the patients who experienced a decline did demonstrate recovery, at least in the short term. So I think it's, it's really hard to know how to interpret this data. We don't have a comparator population. We really don't understand how these cardiac trends would compare to non-liposomal anthracycline or non-anthracycline salvage regimens. And I think really to assess the cardioprotection of CPX-351, it's necessary to do so in a randomized setting. And that is exactly what is the sort of subject of the ongoing randomized phase 3 trial being conducted by the COG right now. Next slide. So this is a randomization of CPX-351 in combination with sort of our standard of care AML-directed therapy, including a FLT3 inhibitor with suspected low rate of cardiotoxicity for patients that have FLT3 mutations. The study chair is here in Seattle with me, Dr. Todd Cooper. Dr. Bonnie Key is the core lab PI doing all the echo quantitation. Our peds cardiology collaborators, Dr. Will Border and Ritu Sachdeva are at Emory, and then Dr. Wilson Tang at the Cleveland Clinic is running the biomarkers. Next slide. So this study will features a randomization during induction 1 and 2 of CPX versus conventional daunorubicin and cytarabine given with desroxaxane. Essentially, both patients on arms A and arm B will receive mitoxantrone, which is also essentially an anthracycline or anthracycline. And that will be given with desroxaxane both on the experimental arm and on the conventional daunorubicin arm. This trial has been open for about a year. We have 173 active sites. We've accrued almost 150 patients to date out of the 1,400 that will be accrued over a 5-year period. And the cardiac studies on this trial are supported by a Leukemia Lymphoma Society Career Development Award, some NCI funding for the biomarker sort of integrated quality of life mechanism, and then Jazz, the pharmaceutical company sponsoring CPX. Next slide. So given the potential for cardioprotection on both arms, while the primary objective of the study is to assess for improvement in leukemia outcomes because of the favorable properties of CPX-351, one of the critical secondary aims is to assess the cardioprotection of CPX as compared to desrizoxane with conventional chemotherapy. So in order to assess this, we will analyze serial echocardiogram based on both site-reported and central review, looking at parameters of LV function and cardiac remodeling. And then we'll also look at biomarkers of cardiomyocyte injury and myocardial wall stress. And then importantly, we will utilize this large at-risk cohort to capture serial imaging and blood biomarker data in hopes of identifying predictors of cardiotoxicity, and ultimately hope to integrate these sensitive echo measures of myocardial dysfunction, such as strain, with cardiac biomarkers and host factors such as genetic polymorphisms to predict more progressive global cardiac dysfunction. Next slide. This is just a schematic of when we're sampling plasma, which is essentially at the end of every cycle. There's a couple of anthracycline containing cycles where we're getting one kind of within 72 hours after finishing anthracycline. And similarly to what Kelly presented, doing echoes at baseline and prior to each subsequent cycle, and then again off therapy. And importantly, the biomarker assays and the central quantitation are not being performed in real time, so all of the decisions at the site level are really being made off of the site read. And then I have a couple more slides here about sort of our practical approach to monitoring for cardiotoxicity and how we've suggested handling anthracycline dose modifications. But for the sake of time, I think we're 3 minutes to the hour. I might skip over this and just welcome any questions from anybody, and would be happy to continue conversations about this trial offline.
Great, thank you so much, Kasey. This is really fantastic, and congratulations on the study that you're doing. You obviously have put a huge amount of work into it, and you have a great team, and I am anxiously awaiting the results whenever they come. And so at any interim analysis, I'm sure we would be very interested if you're planning on doing that. Yeah, I think this is, you know, just a fantastic study, and could potentially answer a number of really important questions. So I think that's really, really wonderful. I think how does this apply in the adult world is kind of the question that we have to struggle with. So I think, you know, that CPX 351 is otherwise known as Vyxeos.
Right.
And right now it has, based on the study that you showed in adults with leukemia, that it has an improved overall survival compared to standard doxorubicin, as in 7+3. But, you know, whether that improves survival is because the drug is better delivered to the cancer versus whether it's protecting the heart and so that people are not having cardiovascular events that limit their life is a very interesting question, and we hope to gain some insight into that. You know, the problem with what you have, this really beautiful study in pediatrics, and putting that in the adult world, the whole calculus has to involve cardiac risk factors in adults. So, you know, those people with hyperlipidemia and diabetes and hypertension, adding that to the mix, at least in the pediatric world, hopefully you don't have to add that to the mix. So.
Right, that is true. We do have the benefit of having a much cleaner population, and working within the Children's Oncology group is really, it is very effective. I think we're able to learn a lot of important things just with the infrastructure of the COG.
This is,
but
oh, sorry.
351, certainly we are we are not eliminating cardiotoxicity by any means. And so I think, understanding, the cardiotoxicity risk stratification and opportunities for secondary cardioprotection are really, I think, still going to be very important.
I have a question. It's Chronic St. Louis. How do you deal with the disparities between the core lab ejection fractions and your local ejection fractions? Because in our study, this was a big problem because one of our early toxicities was based locally, but then the core lab came and said everything was great, and we'd already taken the person out. So how do you deal with that issue where you think you've got toxicity, but if your core lab is the gold standard, you may not have, toxicity? Do you have an adjudication type of deal, or how do you deal with it?
Yeah, it's a great question. I think ours has tended to be the opposite, where the site's function is okay and the core lab is much worse. I think, Bonnie Key clearly has lots of experience in this realm and has invested a ton of work in this ongoing trial. A lot of our focus is really on training sites to perform high quality acquisition. And, I think the hope is with that, with really getting good quality images, that we'll be able to see a little bit more concordance in the site measurements. But really, our focus right now is on education. But, happy to hear from you cardiologists about your thoughts on that and suggestions you might have.
Well, I think, what Kelly presented earlier about, just expecting sites to send their echoes to a core lab is going to raise the standard. So that alone is going to improve quality. So I think, that's fantastic. And so, I mean, I really applaud you guys for what you're doing. This is fantastic. So
thank you.
Well, you had too many questions or too many comments. Maybe they were all from me, but sorry about that. But our hour has gone by quickly, and we look forward to hearing back from you guys whenever you feel ready, and we will be watching your progress closely, I'm sure.
I pasted the references to our recent publications into the chat box, so hopefully you'll check them out.
Great. Yeah, we'll get Steve to hopefully make note of those and send out to any that are interested. I certainly am. But when you start talking about chat boxes, you've kind of gone beyond my level of expertise. So
might be beyond my level of expertise as well.
But we will definitely.
What we can do.
Yes. All right. Well, thank you all so much.
May I ask just a little question, Dr. Linehan? Just a little one, sure. Please.
Just a little.
Sorry, I'm sorry, Kasey. Thank you for your wonderful work. I have a short question about troponins, and we know that it's a very important tool in the success of the protocol in the detection of early cardiotoxicity. But how many hours can we wait to measure it with a secure result? Don't waste time. How long do you wait for this measurement?
I think that is the sort of magic question. It seems like at least in pediatric, or especially in pediatric, there really is a lack of data about the ideal timing to measure troponin. And I think even knowing how to act on that is also challenging. I think because of the data we saw from Kelly, seeing that patients who have cardiotoxicity have lower event-free survival, I really worry about getting things like troponins that cause us to hold back on our anthracycline and then lowering our leukemia outcomes. And so I think we have to be really cautious about that. I think that's why it's so important to study troponins and really understand their role in prediction and association with meaningful cardiac outcomes in the context of this trial. But unfortunately, I don't think we have that data now, certainly not in the context of AML therapy. I think we've chosen to do them at the end of each cycle based on some of the data out of Daniela Cardinale's studies, showing that sort of that prolonged release of troponin tended to have more of a correlation with outcome. But we also chose to do an earlier time point at that day 8 within 72 hours after CPX to try to understand if that also had any sort of predictive kind of association. But certainly happy, especially Dan Lanahan with your expertise, happy to hear kind of more input on what you think about the timing that we've selected.
Yeah, I mean, that's a loaded question, and you know, Veronica asking it after the hour is, you know, it's guaranteed to make the conversation go on forever. But it's a very complex topic. I think we're still, even in the adult world, we're still struggling with the timing issues. And I have my own opinion and the own way that we do it, but the data that supports that opinion is spotty. So it's difficult to answer that.
Yeah, that's fair.
All right. Well, thank you all so much. Again, fantastic
Thanks.
presentation. You are welcome back anytime you want. So.
Thank you all.
All right.
Thank you all. Thank
Bye
you.
for now.
Thank you. Goodbye. Congratulations.